and welcome to this, our Minnesota Health Collaborative webinar on suicide prevention and intervention in the ED. We're so glad you could join us here today. So as we go forward, first of all, I want to give a few Zoom webinar tips. Some of you may be new to Zoom. And as a webinar, you don't have to worry about having a webcam on your end or a microphone. Any questions that you ask, please shoot them through the Q&A piece at the middle bottom of your screen. If you'd like to adjust your audio, that's on the bottom left. You can change view up top. Go ahead and play with things. You'll be able to work it out, and you won't have to fear breaking anything. It's pretty user-friendly. I am Tani Hemela, and I am your moderator today. I am also the lead convener of the Mental Health Acute Needs Working Group, who developed the recommendations that we're going to talk about today. And I'll give an introduction to our presenters. They will come in one by one after I give a brief overview. So today we are so glad to have with us 3 members of the Mental Health Acute Needs Working Group. It's been a great group working over the past almost 2 years now, developing recommendations not only on suicide intervention and prevention, but others. And so today we have with us Dr. Michael Schwem, who is the ED Medical Director at Mercy Hospital and Allina Health Chair, Emergency Medicine Practice Committee of Allina Health, and he's an emergency physician. We also welcome Pam Hyatt, who has a master's in organizational leadership and MSW and is a licensed clinical social worker. Pam is the manager of behavioral health clinical services at North Memorial Health. And we're pleased to welcome also Chris Palmer, Dr. Chris Palmer, who is ED Medical Director at North Memorial Health and an EPA emergency physician. So for our objectives today for this webinar, we hope that you will walk away being able to describe a little bit about how Minnesota Health Collaborative partners are creating and implementing shared standards for acute mental health needs in emergency departments and across systems. We also hope that you'll be able to understand a bit better the need for improving suicide intervention in EDs and learn about Minnesota Health Collaborative recommendations that help support better suicide prevention and intervention. And our main objective for calling this webinar here today is that we are issuing a call to action to those of you here who are members of the Minnesota Health Collaborative organizations, those of you who may be from other health systems and hospitals across the state, and in other organizations in the community, as we test, adopt, and spread these recommendations to improve suicide prevention and intervention in emergency departments. This work here will grow and be further iterated, and we are going to want and need your input as well. So what is the Minnesota Health Collaborative and how did it start? It started with the CEOs of major health systems in Minnesota, both care delivery and plans, coming together and envisioning a new generation of collaboration for healthcare in Minnesota and for health in our communities. They saw a need to come together around tough, long-standing problems that can't be sufficiently addressed by any one organization. And they chose to start with addressing the opioid epidemic and mental health. Here's a list of the Minnesota Health Collaborative partners. As you can see, many of them are based in the Twin Cities metro area. Many also have clinics or are systems based in greater Minnesota, and it's both care delivery and health plans. And we like this slide because this describes how we are coming together. This is not only about a commitment to collaborating, but it's a commitment to community. Both our community that is dedicated to improving the health of others and improving community health. Together, we really have an opportunity here to change a community of practice around the topics that we're working on together. So I mentioned that our first place to start, when the CEOs first convened 2 years ago, they charged us with beginning with the opioid epidemic and mental health. You can see that these are long-standing issues that will take time to work on together. So the opioid work has two different areas. One is in acute pain prescribing, and the other is in chronic pain management and addiction. In the mental health areas of work, we are working on integrated behavioral health and more fully realizing the potential that that would have for better care and access. And what we're going to talk about today, the work in mental health for mental health acute needs in emergency departments. So 2 years ago, this dream of Minnesota Health Collaborative started with the CEOs, and they then deputized subject matter experts in each of these topics to come together and further scope the work. And those discussions then resulted in these topic areas today. So with that, I'm going to hand it over to Dr. Mike Schwem, who will describe how we got started in the work in emergency departments.
Afternoon, everybody. This is Mike Schwem here. Thank you, Tommy. We should first go back to the original situation that brought the group together. Our ED visits have increased over the last 7 to 8 years. However, the visits specifically for mental health and substance abuse, primary chief complaints, has outstripped that pace by about 4 to 5 times. So the number of ED visits for mental health and substance abuse primary complaints has gone up 75% over about the last 8 or 9 years. Continues to rise. Nationally, inpatient psychiatric beds have decreased over this same period of time by about 13% to roughly 38,000 across the entirety of the United States. So this obviously creates a supply and demand mismatch. Within the ED was a very intentional place for us to start. It's within our direct sphere of control, as was stated by the CEOs. From our corner of the world, anything that occurred pre-ED was a little less critical than the care we can deliver with a patient directly in front of us. So patients arrive in the ED for many reasons. It's where they're told to go. We are always open. They don't know where else to turn. And they knew we might have some answers and resources for them. Much of our work thus far has been an attempt to standardize the approach to improve the quality and increase the deliverables we can give to the patients coming into crisis. We are going to continue to work on transitions outside of the ED and across the state to make sure there's a better network of improved patient care and outcomes once they leave our care. Our primary focus thus far has been to ensure the stabilization of the post-ED care is considered and streamlined. The acute needs within the ED main goal is to improve the quality of care of patients in crisis. Naming these as a shared standard as a principle, as opposed to just selecting a practice, was important to maintain that we had crucial levels of engagement and also accountability. We asked ourselves, what can we do to make the mental health equivalent to standardized guidelines for chest pain or sepsis, for example. Our approach to chest pain has evolved over the last 10 years, as has sepsis. There are improved decision tools, there's augmented outpatient resources. We would like to do the same for mental health. Gradually, our approach to chest pain and sepsis has changed the local standard of care, and we think we can do the same for mental health as well. Thus far, a large part of what we've done is standardizing both the clearance, suicide screening, identification, and a huge part of this, and this cannot be understated, is simply gaining trust between departments, specialties within the hospitals and hospital systems. We can do this by standardizing the identification and intervention that we do for patients while in the emergency department. Standardized tools, likewise, like the Columbia, they're evidence-based, they're easy to roll out, and they ensure we're all speaking the same language. And we still have some opportunities for crisis de-escalation and closing the loop following an ED crisis intervention, and that will be coming forward. And I'm going to turn this over to Pam.
Thank you, Mike. Okay. Well, as we all work on the psychiatric unit or in the emergency department, we all work with suicide daily. And as professionals, we work with it. But when it becomes personal, it's a different story. So I'm going to share with you a couple stories. There was a Minnesota family, Danette, Beth, Eric, Zoe, and Linnea. Danette found Beth, who had died by suicide in her garage. 2 years later, Beth's brother, Eric, died by suicide after a breakup. 1 year later, Danette ended her life the same way that she found Beth. 6 months after that, Zoe ends her life by suicide. And then 6 months after that, her daughter attempts and survives. 28-year-old Karen, I'm sure you've all had these patients in your emergency room and on inpatient site. Karen was with us for 2 months on the inpatient psychiatric unit, and we saved her and until we discharged her to a intensive residential treatment facility, which 3 days later she left and died by suicide. Ariel. 7 weeks ago, I attended the funeral for a 13-year-old. Suicide is the second leading cause of death for 10 to 24-year-olds. So how can we better support each other, the people that are in crisis? When somebody's thinking of dying by suicide, how do we risk, or how do we decide their level of care? So we have a lot of opportunity here. One place to start is by improving interventions in the ED to better support both at-risk patients and the people who care for them. By improving our screening process, we start the conversation about suicide. We make it okay to talk about suicide. We talk about the pink elephant in the room. We use evidence-based assessments and interventions. We provide guidelines to those that are new to the work, not relying only on clinical skill, but a marriage of the two of them. By talking, we challenge our cultural bias, stigma, and discrimination. Thank you. So the need is great. It couldn't be more clear. Approximately 123 Americans die by suicide. There is one suicide for every 24 attempts. Minnesota alone saw a 40.6% increase in suicide from 1999 to 2016. The only state that did not rise in suicide is Nevada, as you can see on the photo here. So we have an opportunity. The opportunity is we are at a critical place, a critical point in improving our interventions to support those experiencing suicide in the ED. For some folks being seen, it might be the only mental health treatment that they get. For others, it might be the beginning of many visits. So what we've done here in getting together with the Minnesota Health Collaborative, we are different systems, populations, and resources. And what happens when there's a crisis? We all come together. We make a community. And we're a community of professionals that talk. I joined the collaborative a year ago and found my voice, and I've gotten professional support. And then we get together and talk about, Tanya brings us homework. Can we go back to our facilities and encourage the conversation? And just like with all cultural diversity, there's barriers, similarities, and differences. We adapt and support. We become flexible. One of the learning moments for me was when we were all ready to decide on the universal screening tool, the CSSRS or something like that. We're all ready to agree on it. And somebody says, hey, we don't have resources in our emergency department. We don't have mental health practitioners. So we took a step back. We're looking at the situation. We're accepting their limitations, and we're moving forward, taking those limitations into account, because we are a family. We have the same patients. We have different patients, but most of them are the same. So now the work. We receive evidence-based research. We review it. We share the learnings. We understand it. We learn together. One thing that I really learned is the first questions we ask somebody, it's a screening. It's not the only assessment. So we screen, we are managing suicide. We screen and then we intervene. We assess. We're always assessing. And we engage in this, our organization, to pay attention to what we're doing. And we ask for feedback, and we get it. We're aligning with the regulatory requirements by the Joint Commission, who said that we desperately needed to improve our assessments, and not to mention the ligature risk and the environmental concerns for those that are at risk for suicide. But we're also able to talk about how do we assess the level of risk for the patients. So we're learning on implementing. What do we need to do next? We work on training, we work on workflow. The team of ICSI called all of the hospitals and asked for our workflow. They gave us suggestions of where we could improve. So we're all having this self-awareness of where we are in our organizations. Lastly, I'm going to make the note that you probably read it, but up to 70% of the patients who are seen in the emergency department, they don't go on, they don't meet their first appointment. So that makes the opportunity and the work even greater of what we can do in the emergency department. So any interaction that you have with a patient, whether they're suicidal or not, or coming in for a medical issue, let's say, and they end up maybe, as you dig down, find out that they have mental illness, or maybe no mental illness, maybe they're just suicidal for whatever reason. Just know that we're all in a continuum. We all face mental illness every day. I'm going to turn it over now to Dr. Chris Palmer. Thank you.
Thank you, Pam.
Hello, everyone. Thanks again. I'm Dr. Chris Palmer, North Memorial Health. I want to thank Dr. Schwim and Pam for kind of setting the stage on the mental health situation we're facing, as well as some of the work that ICSI's done. My task, primarily in this talk, is to give you a little bit of the meat of what we've accomplished thus far, and I think laying that out for you in a usable fashion is my goal. With subsequent follow-up from you to find out the details that may be applicable to your particular institution. First of all, I think Pam said it well that screening is an important portion of this work. For those of you who work in emergency departments, we know that many times patients present with symptoms that are non-mental health related. However, the crux of their problem may be mental health related. The headache, the abdominal pain, that is a manifestation of their underlying mental illness, or depression or anxiety is a commonplace. We recognize this, we've known this for years, and how do we help parse those people out? So choosing the population within your institution and your emergency department is step one. Many places have gone to universal screening for mental health using some of the tools that we'll outline very briefly as well. You can also choose a more targeted population, those who present with mental health complaints or maybe at higher risk. As we know, the Joint Commission, as well as other regulatory agencies, are following this and recommending screening tools be performed. So once you decide on that, the tools, what tool to use, what's present, what can we use to help identify people and match them to the appropriate tools. A few of the tools that we have reviewed and recommended that are evidence-based are the Columbia Suicide Severity Rating Scale, very frequently and easily referenced as the CSSRS now. It rolls off my tongue much more than it did 12 months ago. And then the Acute Suicide Screening Questions, the ASQ test. Both of these are evidence-based, they have good validity, and they can be implemented in a way that can be useful in your emergency department. Following the use of those screening tools, it's really the risk stratification that presents at that point. Each of these rating scales may result in a different level of risk, and how do you then utilize the resources present at your institution and direct them appropriately to each of these populations to get benefit for each individual patient. Second portion of the process in the emergency department that we've addressed and attempt to find evidence-based tools and useful tips for people is the assess and intervene. This is often a bit of the gap that was present in emergency departments prior. Training of emergency physicians and emergency advanced practice clinicians often not directed in this particular category of patients. However, as Dr. Schwinn pointed out, with the growing population, we need to learn and grow our own skills. We've also, in this particular category, identified evidence-based tools to help with the assessment, evaluation, and safety planning for these particular individuals. Listed in the first are a few tools that we have, again, recommended: the safety interview, safety planning intervention, and we already mentioned the CSSR risk assessment tool, as well as the 3 tools that are listed shortly after that. Additional details are about each of those tools are a little bit outside of the scope of this particular discussion. And I also want to point out the fact that each of these are in fact tools, and they should not completely replace provider judgment and provider intervention in each of these cases. That screening tools are just that. They are tools, and you need to use them in context of the individual patient that you're assessing in front of you. Following that assessment intervention, really the next decision is the one we come to frequently. What do we do next for this patient? How do we decide what to do? And those assessment and intervention tools can be helpful. The various avenues that seem to be most, that are very obvious, I believe, is one is you continue to observe and treat that person within your emergency department walls, whether by choice or by need. This is happening across the greater Minnesota and greater Minnesota regularly. But what do you do during that observation time that may advance care is very important. Does the patient require admission to an inpatient behavioral health unit, or can they be discharged home with a safety plan? Each of these are potential outputs following assessment intervention. The next step really in this is post-discharge follow-up. How do we bridge and get that percentage decreased in the patients that don't follow up for their mental health complaint in the emergency department? 70% failed follow-up is a staggering number, given the acuity and the impressive outcomes that can occur from this particular disease process. There's still gaps in this area. We need to identify what resources are available and bolster them in a way that we can provide warm handoffs for patients and provide them the next step easy and accessible so that they can get the mental health care that's required. An initial step that we've talked about that is within the scope of the emergency department is sending letters or postcards of support. And this has shown a significant preventative effect. Each of our institutions are each early on in considering this process as a way to try and decrease the effect of suicide in our state. So with that, I want to move on a little bit to what we've accomplished thus far at North Memorial Emergency Department. And I'll turn over 2019 plans to Pam following this. In 2018, we've implemented universal screening guidelines at our emergency department. So each patient that enters our emergency department undergoes the Columbia Suicide Screening Rating Scale, and based on that result, gets various interventions or focused care for their presenting complaint. Based on that result, we are implementing suicide precautions, making sure there's not ligature risks, providing one-to-ones when required. And following that, it's really risk stratification, updating our policies and protocols on suicide to provide the least restrictive location for patients based on their risk. And then engaging team members in discussions so that we can take the next steps with destigmatizing? Thank you. Mental health, and so that we can have a more open dialogue about it and approach it similar to what Dr. Schwinn had mentioned as chest pain pathways, as sepsis pathways, so we can provide people evidence-based care and intervention for their acute mental health needs. With that, I'll turn it back over to Pam for some of our 2019 plans at North Memorial based on our interactions with ICSI and the collaborative.
Thank you, Chris. This is so exciting to have leadership at our hospital here and talking about what we've accomplished, because now I know that he's got a foot in the door for what's happening next. So what's happening next is we're going to implement the CSSRS screener for children with a handout for parents explaining what suicide is, numbers that they can call, and yeah, we're going to do that. So I'm excited for that. That'll happen in the middle of the summer. Then we're going to select our evidence-based tools for managing suicide. We've already been having meetings. I've been having meetings with our emergency behavioral health clinicians in the ED, and I've been talking about it for about a year. Every time we have a meeting, I come back and I bring to the team tidbits, so hopefully it's all gathering and forming in their heads. Next is to educate and formally train, not just the team, but the hospital. This is a big stretch here, but I really think that we all need to know. We all need to be more aware of suicide, what it really means, what it doesn't mean. These people aren't crazy. They're just trying to get rid of their pain. Then we're going to talk about post-discharge follow-up. Perhaps introduce the caring contacts, and we'll talk about that with our leadership. So I'm really glad that Chris is here because he's one of our leaders. And then we're going to decide on measurement metrics. How are we going to measure what we put into place? And that will bring the data, and you know how that data speaks, like follow the money, right? Follow the data. So this is pretty exciting. I'm going to hand it over now to Chris. Thank you. Dr. Schwartz.
Hi, this is Mike Schwem from Alina Health again. I'm going to go run through some examples from Alina Health we've rolled out over the last year, and we'll continue to work on improving. In 2018, we implemented some universal screening using the Columbia for every patient that's coming into the ED. As Chris mentioned before, patients that present with abdominal pain, chronic headaches, chronic pain of other sites frequently have an underlying mental health issue that they really want to talk about but may not be open to, at least at triage. And so universal screening does help us pick up some patients that would benefit from a more in-depth mental health assessment. The universal screening also helps us pick up those that would have otherwise fallen through the cracks. We also rolled out a team assessment approach to patients presenting with a primary mental health need, which involves the clinician, our crisis worker, and nurse all at the same time. That helps us identify patients that would be maybe more likely to escalate. We don't use a one-size-fits-all policy for this. Not every patient with an infection needs the same amount of or intensity of monitoring either. So it allows us to help select those patients that are most likely going to need immediate stabilization, ramping up of overall level of care, perhaps medications, and maybe even inpatient resources versus those that simply need someone to talk to while they're in the emergency department, de-escalation, and outpatient resources. We will be implementing an ASQ for our pediatric population, our patients aged 10 through 17, which is very similar to the Columbia for children. And then by March 2019, actually right now, we should have the risk stratification protocol rolled out at all of our EDs. Partnering with our psychiatric colleagues has been really crucial for making this all work, including telepsych, and we do have some more training in suicide assessment and safety planning that is going to be conducted over the next couple of months. More to come though. There's going to be more training, particularly for our ED clinicians and our assessment referral, which is our crisis social workers and psychologists that staff our emergency department, as far as early de-escalation, improving outpatient resources, improving outpatient referrals, and making sure those referrals continue to be open. We are also going to be doing some follow-up close contacts to ensure that that loop is closed for the people that we do set up outpatient resources for. Closing that loop and scheduling the outpatient appointments while the patient is in the ED is obviously far better than handing someone a list of numbers. And we will be following our ED metrics as well.
Well, thank you all. This is Tommy again. And so we wanted to make sure to allow enough time for you all to be able to ask questions that I'm sure you have. So please use the Q&A feature in the bottom center of your screen. I'm going to mention a bit about where we're going from here. So these organizations together, as you've heard from Pam, Mike, and Chris, they have developed together, here's a pathway, and have done some, not only the review of the evidence, but also some important conversations about practical considerations for organizations with differing resources and differing needs. And that iteration will continue. So right now, next week, when you receive the follow-up from this webinar, you will receive also a link to the recommendations themselves that include the evidence summary behind them, of course. So that comes out next week. These organizations, as you've just heard from both North and Align and the others are doing as well, are all making changes throughout this year. And we want to make sure to incorporate that and be able to gain from it. And they are all willing to share that and add that to the recommendations to be able to provide more implementation tips and assistance. Furthermore, we also want to be able to get input from you. So we're spreading it with other health systems. The need is great. This is a time for generosity and a time for sharing. And so we hope that we will be able to hear from you your thoughts on it after you review them in the coming weeks. So I'm going to pause for a moment. Let's see, I see that we have, I hope there's a question here. There's a question. You are going to be receiving handouts. We will send out the slides and the recommendations next week. So those of you who are listening in, we've got quite a group here that are listening in out there. So this is your chance. You've got 3 people who have been working on this in their systems and will be for the coming year and more. What questions might you have? Please go ahead and type them in. While we wait, I'm going to look to our presenters and ask, what else? You all worked hard to, we had conversations about how do we distill this presentation down to, some brief points and allow time for questions and have it focus. So I know there's a lot more to say. Anything else that one of you would like to add?
I think one of the things that I want to bring up and make sure it's covered here is you can't underestimate, as Dr. Schwim said in our pre-planning for this, the importance of the relationship building that's required to make trust across specialties which were previously siloed, the emergency department and the care present in the emergency department. And then our job was to assess whether or not they needed the next silo, which is the psychiatric care that is in a different unit at a different location. What we've done at North Memorial is try and meld that care a bit by bringing psychiatry into our department more regularly, seeing the patients who are waiting or on observation or pending for admission to get care started earlier and start the therapy as early on in the process as possible. We all understand the limitations within the emergency department. The physical plant is not ideal for healing for mental health or getting rest or getting the things that are required to improve your mental health. Population, the psychiatrists were able to identify some of the areas where we could provide some of that care early on and hopefully decrease length of stay, get patient improvement much earlier on so that we can continue to serve as many patients as possible.
Thank you. And thanks to all of you out there who are sending in some questions here. One question is about who does the Columbia, triage nurses or behavioral clinicians? Mike?
I can answer that. So our triage nurses do the Columbia screen. There is a more in-depth screen that gets done by our assessment referral clinicians. But triage has always done suicide screening. They have for many years now. The Columbia was just a more universal way to approach this to ensure we weren't missing anybody. So it is done at the same time of arrival along with the chief complaint and vital signs.
And we do the same at North.
Pam just said that they do the same at North. I'm repeating that in case listeners couldn't hear. So another question is about the team assessment and its benefit. So Elena works, so Mike?
So I can talk about this a little bit. The team assessment is an approach to ensure patients that are experiencing mental health crisis do not have to repeat their story 3 to 4 times on their way to finally get some help. The patients are brought back as quickly as possible, placed in a safe area, and it's called out overhead much like a stroke or a heart attack would when patients arrive in the emergency department. The expectation is that it is completed within 20 minutes of patient arrival. Sometimes that's possible, sometimes not, but the goal is to ensure every minute of that patient's time is value added. If someone's tied up with another patient need at the time and cannot immediately attend, the process does not stop moving forward. So we're still able to get the history, get medications on board if the situation dictates that that's necessary, will be helpful. We, when I say we, I mean our crisis clinicians, the physician, and the nurse taking care of that patient will all go through the same set of questions one time with the patient to assess their acute risk. That allows us to all be on the same page at the same time, and generally within about 5 to 10 minutes we have a pretty good feeling as to whether or not that patient will need more resources or even potentially inpatient resources or de-escalation while in the ED, or whether this is someone that simply needs resources arranged for them as an outpatient. This allows that patient to be in the least restrictive environment as possible, and helps us identify those patients that do not need a 6 to 8 hour ED stay. They need resources arranged and then they are free to go home. This has actually decreased our amount of code greens, and we call it code green someone that becomes violent or agitated. We found that a lot of code greens happen with the changing out process of getting someone changed into behavioral health scrubs we don't use nearly as often anymore.